screen now?
No.
Okay. Do you know how I can do? Remember?
Now have a great meeting.
Yeah.
How's the mountains? Yes, the mountains I see.
Yeah. That's the beautiful mountain. That's the Alps. But now you should see the PowerPoint. Yes. Is that right?
Yes.
Okay, good. So we'll get started. I will try to keep that within 30 minutes. This is to present the echo imaging acquisition protocol. And first, thanks to all of you for your participation and contribution to this very exciting trial, the REA trial. So I am Philippe Pibarot. I am the director of the Echo Core Lab of the Quebec Heart and Lung Institute in Quebec, Canada. And well, the agenda today, we're going to go through the Echo Core Lab workflow, and then the steps that needs to be done to qualify the site by the Echo Core Lab. Then also I will review the documents that will be provided to the sites, and this includes the presentation. You will have the slides and the PDF of the presentation I will give today, as well as some other documents that will help you to do the echo imaging for the trial. And then we'll cover the objective of the echo imaging protocol, the examination, preparation, and positioning, and general procedure. As well as the image acquisition sequence. And at the end, we'll cover how to transfer the echo to the core lab, but there are also some specific tutorials for that. So what you see here is the workflow of the core lab. So the images are transferred to the Echo Core Lab from the sites to the Echo Core Lab by the Ambra Healthcare, the image share platform. And then we have a reception of the echoes by the coordinators, which are then dispatched to the sonographers for analysis and measurements of the quantitative measures. There is then in step 4 an overread by the cardiologist. And then finally, I am overseeing all the echoes and do the final validation, and all the data are entered in a ECLF web-based database, which is a clean case. We use, if you're interested, we use the TomTech software and platforms to do all the analysis at the core lab. So the step for qualification of the sites. Step 1 is to attend this webinar. So this is the first step that is done for you. Step 2 is Christine will send you a quiz with 12 questions to confirm the learning objectives, and you have a maximum of 1 error. And if this is okay, then the step 2 is done, is fulfilled. Step 3 is to submit 1 sample qualification echo that is complete and it's compliant to the protocol. So you send us, it is not necessarily an echo done in a patient to be randomized in the trial. It could be an echo in any other patient that you have in your clinic. The echo needs to be anonymized and sent to us, and needs to have all the images and signals that we request. And when it's done, I'm going to send a QA form, and then if the 3 steps are fulfilled, then there will be a certificate that will be prepared by the core lab, and you are then certified. So the documents that will be provided will be the training slides that I will show you today. So you can review in more detail and with more time later on, if you will, if you want. And then there is also a more detailed image acquisition protocol manual that is or has already been provided to you. It's a guide following the same structure as the slides, but with more details. Then there is a two-page imaging acquisition checklist that the sonographer or cardiologist can use at the time of the echo to remember the imaging sequence. And then also there is a site echo quality assessment form that is just for information, just to show what we are using as criteria to assess the quality. So the objective of this echo component of the RHEA trial is, of course, to establish the baseline cardiac anatomy and function with a strong emphasis on the aortic valve, and also a very important objective is to assess in the follow-up echoes the function and morphology of the aortic valve device, which will be the SAPIEN 3 in one arm and a bioprosthetic valve in the other arm. So this is the schedule of the echo visit. So there is an echo at baseline screening that is in the windows of 90 days prior to procedure maximum. Then there is a post-procedure echo that is could be done early after procedure at the time of discharge or whatever. It's called post-procedure, and it's more for safety purposes. Then there is a 30-day echo that is with a maximum window of plus 10 days, and then the 1-year echo with the maximum windows of plus 30 days. So 4 echoes, 4 transthoracic echoes to be sent to the core lab. So well, this is the requirements in terms of system that needs to be used. We would like you to use a state-of-the-art Doppler ecosystem, a newer generation. So this could be Philips Epic IE33, Siemens Sequoia, or GE Vivid E95 or E9, with the typical probe and frequency range that you are generally using. Ideally, a qualified physician or sonographer, and ideally the same group needs to do the echoes to minimize interoperability. So if throughout the trial you can use the same group of people, sonographer, cardiologist, and also same type of machine or same machine to do the echoes in the trial, that would be very much appreciated. Of course, you need to explain the procedure to the patient. Typically, we'll do the echo in the lateral decubitus position, so it's more like general, usual procedure that you do for any echo. One thing that is important is that there is no patient personal identifier visible in the name of the echo file or in any of the images that are captured, so it needs to be anonymized. And it is important to enter the patient study ID that is specified in the case report form. We'll discuss the structure of the patient ID later on. We need to have a high quality ECG with sufficient amplitude of QRS. As you know, it's important for analysis of the echo images. Then in terms of number of captures and number of bits per capture, for each type of image or signal, we like to have at least 2 captures, so 2 acquisition. If you give us 3 or 4, it's even better. And per capture, it's generally a 3-bit acquisition if the patient is in sinus rhythm. If the patient is sinus rhythm but tachycardia or AFib or atrial flutter or arrhythmia, then we like to have longer capture, more bits. So don't hesitate to give us more images if the patient is arrhythmic. Of course, well, then this slide is more about the general recommendation. Of course, the image needs to be stabilized. You can use breath holding if necessary, and you need to optimize spatial resolution, etc. In terms of frame rates, the minimum frame rate for 2D imaging is 40 frames per second, and for color Doppler is 20 frames per second. This is generally with the new generation of Doppler ecosystem, there is no issue in getting this level of frame rates, and it's all resting echo, so you should not have a difficulty to achieve this goal. In terms of the spectral profile, and especially the sweep speed for the spectral Doppler, we like to have the longer one if possible, so 100 millisecond per centimeter. That's the one we prefer. And in terms of the Nyquist settings for color Doppler, well, we align with the ASC guidelines, and generally your settings should be between 50 and 60 centimeters per second for color Doppler. And there is no quantitation of MR or AR that is planned in this trial, so there is no need to decrease the Nyquist limit. So you can do the measurements and the tracing. We understand that for the clinical follow-up of the patient, you may need to do these measurements, and you can leave the measurements on the images and the exam that you send to us. But please make sure that your measurements do not obscure the other beats, the flow profiles, and make sure to leave us several beats or images that are untraced. We will redo all the measurements. So contrast. You can use contrast if you want to enhance visualization of endocardial borders, but if you use contrast, please do more at the end of the exam, as we usually do, and please make sure that you're going to acquire your Doppler, spectral Doppler acquisition prior to contrast, because as you know, when you give contrast and you do Doppler afterwards, maybe sometimes the signal is overgained. This is the image acquisition checklist that we will provide. So it's a 2-pager. It's very simple. It's just to remind you the sequence of imaging. But as you will see, this is a complete transthoracic echo, but this is the usual images that we acquire in a routine echo in a patient with valvular disease, with aortic valve disease generally. So the examination sequence starts with usually with the parasternal long axis, and with measurements of 2D on the ventricle and the LV outflow tract and aorta. We need to have 2D and color Doppler. In this example here, I have shown, although the video clips are not playing, but I've shown some paired images. We like to have paired images, 2D color Doppler. This is okay because it helps to better interpret the echo. But if you do paired imaging, please make sure to also give us the 2D and color Doppler separately, because the limitation with paired imaging, such as shown here, is that it reduces substantially the frame rate. So if you do paired, it's okay, but also give us 2D. For the parasternal long axis view, we would like to have one that is on axis, which is best for measurements of LV dimension, but another one which is more like what we call a low window, that is best for optimization of visualization of LVOT and aortic annulus. So this is an example here where for the LVOT, there was only provided a view that is not magnified, and ideally we want a broader view, but also a view that is zoomed and focused and optimized on the LVOT and aortic valve. This is, as you know, a very important measurement, the LVOT diameter. So you want to make sure to really give us several video clips, and we need the video clips. We don't give us only the still images, because we're going to select the frame on which we want to measure the LVOT diameter. So give us several video clips, 2D color Doppler as well, to show us the LVOT. And as you know, we often tend to kind of sometimes truncate the imaging of the LVOT. So you need to ideally find the plane that maximize the size of the LVOT. So that would be the plane that is represented by the double yellow arrow here. So in other words, you have really to optimize the imaging of the LVOT and trying to find the view that provides the largest annular diameter and LVOT diameter. This is just to illustrate how we measure the LVOT diameter prior to intervention on a native aortic valve stenosis. You don't need to do this measurement. If you want to do them for clinical follow-up, this is fine, but you can also just leave the untraced images and the video clips, it will be fine. For the measurement after aortic valve replacement, but this is just again to illustrate how we do, and you may probably do the same in your lab, we measure the LVOT diameter from the external border of the stent to the external border of the stent to calculate the stroke volume and valve area by continuity equation. This is how we typically do. And so again, a good imaging, a good video clip focused on the prosthetic valve and LVOT is critical. The high parasternal view is also in the imaging sequence, especially important for measuring the diameter of the sinuses and aorta. It is important to emphasize that one of course, the main focus, the main primary endpoint is the transaortic and then transprosthetic pressure gradient. And so it is extremely important to have a multi-window interrogation with continuous wave Doppler. And this is a slide to illustrate that often we believe that the maximum velocity is obtained at the apical, 5-chamber or 3-chamber views, but in fact, some studies suggest that in up to 50%, the highest velocity will be recorded at the right sternal border. So it's very important to do the right sternal border. And this is just to illustrate the same patient. If we had only interrogated the apical view, we would have concluded that, well, this is a non-severe yes, and so the patient is not eligible for the trial. Whereas if you interrogate also the right sternal border, we find a much higher velocity and severe yes, and then the patient is eligible for the REA trial. So then, if we continue in the imaging sequence, there is the right ventricular inflow view that is also standard in an echo, 2D color Doppler, continuous wave Doppler across the tricuspid valve to estimate the right ventricular systolic pressure, and the right ventricular outflow view, again 2D color Doppler, and pulse wave Doppler of the pulmonary valve in the RVOT. We sometimes use this measurement to calculate the RV stroke volume and do like a QPQS to estimate or quantitate indirectly the aortic regurgitation, if any. Then the parasternal short axis, we take the parasternal short axis first at the left ventricular level, at the 3 levels as usual. And then parasternal short axis, we go higher, and the one at the aortic valve level is extremely important. 2D color Doppler to assess, to visualize the leaflets, both prior and after the procedure is very important. And also the color Doppler is of course important to assess and the degree of transvalvular or paravalvular AR. And then this slide is to emphasize the importance of multi-window imaging for the assessment of AR. Of course, we will be very interested in assessing and grading the severity of AR, again, transvalvular, paravalvular, before and after AVR. And so we need multiple views and multiple plane with color Doppler to assess the jet. So the parasternal short axis is extremely important, parasternal long axis as well. But as you know, after TAVR or SAVR, often the jets that are located posteriorly, the red ones, are often shadowed or occulted by the material of the prosthesis, and often we see better those posterior jets in the apical view. So the apical 5, apical 3 chamber. You can also gives us some intermediary views, like intermediary between apical 5 and apical 4, sometimes useful to better visualize some jets that are lateral or medial. And so this is meant to show, but the video clips are not playing with this platform, that it's not only a multi-window, but often we want to have multiple planes. For example, in the short axis, it's good to have several slices to have an imaging at several levels because, for example, to visualize a transvalvular ER, you may want a plane that is higher, whereas to visualize better the paravalvular, you may want a plane that is more like lower or more apical. So give us more planes, and you can also do a sweep where with a probe you're traveling from the aorta to the LVOT in the short axis view, for example. This was just to illustrate, but and that's what is shown here. We are in the short axis, but we have short axis imaging at 4 levels. High in the, at the above the stent, then more like in the upper portion of the stent, mid portion, and lower portion of the stent. So then there is a parasternal short axis aortic valve level again. Well, 2D is important, and also we do continuous wave Doppler on the tricuspid valve and the pulmonary artery, pulmonary valve. Then we move to the apical. So now we've done the parasternal, we more now apical. Apical 4 chamber is, of course, a very important one. We want a view that includes the 4 chambers, and then another view that is more focused on the left ventricle, optimized for the left ventricle to measure the LV ejection fraction. As you know, one of the pitfalls with the biplane Simpson and the imaging related to the biplane Simpson is the foreshortening of the apex. So try to avoid the foreshortening of the apex. Try to get the images that provides the longest LV cavity. This is true for apical 4, but also for apical 5. And in the apical 4, we need 2D and we need color Doppler for assessment of MR and for assessment of PR. Apical 4 as well, this is, as you know, the view that we use for assessment of diastolic function. So pulse wave Doppler at the tip of the mitral leaflets. We also ask you to do a continuous wave Doppler through the mitral valve for assessment of eventual concomitant mitral stenosis. And then Doppler tissue imaging on the lateral and septal aspect of the mitral annulus, again for assessment of diastolic function. In this trial, we will also assess the right ventricular function. So when you do the apical 4 chamber, please also give us some apical 4 that are optimized for the right ventricle. So where you center the right ventricle in the image and you really focus on the right ventricle, because we're going to measure the TAPSE by the 2D method. So you don't need to do the M mode, but we're going to assess the fractional area and the TAPSE by 2D using these optimized images for the right ventricle. So when you do the acquisition, please think about the right ventricle as well. Because we have seen, in particular in some previous study and in partner 3, that TAVR appears to better preserve the RV function compared to SAVR. So that will be an important echo endpoint here. So this is just to show some example of 4-chamber views that are really optimized for and focused more on the right ventricle. And this is just to illustrate what we will do with that. If you provide us those images optimized for the right ventricle, we do the TAPSE, but by the 2D method. So we measure the length in diastole, in systole, and we do the difference, and the difference is the TAPSE. We will also, again, for assessment of RV function, do the Doppler tissue imaging on the free wall aspect of the tricuspid annulus. So when you do the Doppler tissue imaging in the 4-chamber, you know, for assessment of diastolic function on the left side, at the same time, please do also the right side, because we use the S' velocity of the tricuspid annulus as a parameter to assess RV function again. Then apical 5-chamber view is an important one, and both before and after intervention. This is here for the native valve, but for the prosthetic valve also will be important. So what we need is 2D. We know the pulse wave Doppler in the LVOT. It's extremely important, as you know, to measure the stroke volume, and the continuous wave Doppler, of course, through the aortic valve. So please show us a video clip if you can, to show us where you position the sample volume. That should be around a few millimeters below the aortic valve before transferring to the pulse wave Doppler mode. And this is an example of what should not be done. For example, here we have only one acquisition of a pulse wave Doppler, and well, some beats were masked by the measurements, and the others were all traced. And so we don't have any free of trace beats. So it's okay for you to do the measurements, but if you do that, provide us more acquisition, more capture to give us cycles that are not traced and not masked. This is apical 5-chamber, but illustrating more for when you have a prosthetic valve, so after AVR. Well, same principle. You want to do pulse wave Doppler in the LVOT, continuous wave Doppler through the prosthetic valve. Generally, we do when it's a TAVR, we do a pulse wave Doppler just below the stent and just in the apical portion of the stent, so the pink and blue one. But I would say that the most important one is really the pink one, so the one that is just below the stent. Because as soon as we enter in the stent, there is some flow acceleration and we may overestimate the stroke volume and valve area. So what is really important is to be just below the stent. And same for the surgical valves. Well, there is only one sample volume that is relevant, that is just below the, not the stent, well, it is the stent or the severing ring. So the pre-stent velocity. For the continuous wave Doppler, it is important to emphasize that we like to have this continuous wave Doppler in grayscale. I know that colorized images are maybe better looking, but for us in the Colab, it may cause us some trouble in terms of post-processing. So just give us the plain grayscale color, continuous wave Doppler. Apical 2-chamber is another one that we use for the LVF by Blaine Simpson, as you know. So again, we need a good view focused on the left ventricle. Again, trying to avoid foreshortening, and also you can do, of course, color Doppler in the mitral valve. Apical 3-chamber view, we need a 2D view. We need a color Doppler on the mitral valve, color Doppler on the aortic valve, and of course, we're going to do the pulse wave Doppler in the LVOT. So we repeat the pulse wave Doppler in the LVOT in the 3-chamber view, as well as the continuous wave Doppler. This is extremely important. So I will go fast here because it's the same as the apical 5-chamber, but we need several pulse wave Doppler acquisition in the LVOT and several continuous wave Doppler through the valve. This is for the 90 valve, and now for the prosthetic valve, TAVR or SAVR, because it's a randomized trial. So comparing SAVR versus TAVR. And then we're almost at the end. Generally, that's the view that we do at the end. As you know, the subcostal views to the color Doppler of the aortic valve, color Doppler of MR and TR. Optional, but diastolic flow reversal of the upper abdominal aorta, especially if there is any evidence of significant AR. And again, illustrating subcostal views. The last, but maybe not the least, the right parasternal view is very important, especially for continuous wave Doppler interrogation of the aortic valve, because again, this is often where we're going to get the maximum velocity. So please make sure to systematically interrogate the right parasternal view. And the suprasternal notch, we like to have a 2D, and again, the diastolic flow reversal here in the descending aorta with pulse wave Doppler. This is used essentially, as you know, to again, to assess the severity or corroborate the severity of AR, if any. So if you don't have any AR, that is, if it's only non-trace, you don't necessarily need to do that. You can end earlier. But if you think that there is potentially some significant AR, would appreciate to have this image as well. So now it's more like how to transfer the echo images to the Echo Colab. There are some specific tutorials that can be provided by Christine on how to upload the echo images on the system that is called Image Share. that is hosted by Ambra Health. So you go to this website that you have the link here. You log in, and then you choose the type of images to upload. And then there is a little a brief transmittal form to fill. You have to select the type of image. It could be a CT, a TTE, or TE. In our case, it will be essentially, most of the time will be TTE. Sometimes you may want to submit a TEE for safety purposes or whatever. There will be a selection of the visit. This is extremely important. You have a baseline, which has a code 10, discharge, or in fact, this is not discharge, but this is what we call post-procedure, 30 days and 1 year. Then you enter the weight in kilo, the height of the patient in centimeter, because we use this to calculate BSA and index some parameters such as left atrial volume. Systolic and diastolic blood pressure at the time of echo would be really useful. I know that most labs, they measure the blood pressure at the time of echo. So if you have those values, please enter. Then you have the name of the uploading physician. And this is just here entering the patient code. The patient code, so the patient study number is the structure. There are 2 letters that identify the country. So FR, for example, is for France. Then the first 4 digits here, 1401, are the site number. I think this is Toulouse here. And 01 is the patient number. So but all this is well explained in the tutorials by Image Share. And there is also a specific tutorial that describes the patient coding. And then any comment if you have, then you have to click a few things and it's done, you can upload. So on this, I thank you very much. You have my email here on this last image. Please do not hesitate at any time from now to any time in the trial. If you have any question, to write me, and we can also organize a phone call or even a webinar to clarify things if needed at any time. Thank you very much for your attention. And if you have any question or comment, please don't hesitate.